All right, so we are in the breakout session for maternal early warning system, and I'm Christina Davidson. This is Carrie Epps. We're both maternal fetal medicine specialists at Baylor College of Medicine in Houston, Texas, and we also co-chair the Obstetrics Committee of the TCHMB, and the maternal early warning system has actually been our QI project over the past year. We've probably worked with a lot of you before on trying to help implement this in your hospital. So we are very happy to have Dr. Larry Shields with us today, who really is a celebrity to Carrie and myself because we have put his publication up in every presentation we have ever given about maternal early warning systems. So Dr. Larry Shields is a maternal fetal medicine specialist and practices in the Central Coast Division. After completing his fellowship in MFM, he spent the first half of his career at the University of Washington in Seattle. Since returning to California in 2006, he has served as Director of Perinatal Services at Marion Regional Medical Center. He has been an active participant with the California Maternal Quality Care Collaborative, where he served as a member of the Pregnancy-Related and Pregnancy-Associated Mortality Review Committee and was co-author of the CMQCC Maternal Hemorrhage Toolkit. He served as co-chair and editor of the Preeclampsia Task Force and Toolkit, and most recently was a member of the Sepsis Toolkit team. Over the past 10 years, he has focused his work on reducing maternal morbidity related to maternal hemorrhage, treatment of hypertension, and the response to abnormal maternal vital signs with the development of the Maternal Early Warning Trigger Tool. So please join me in welcoming Dr. Larry Shields to the stage.
There must be some sort of bill coming in the mail. I'm not so sure. Thank you so much for the kind introduction. I just want to say it's an amazing honor to be back in Texas and to see there's a huge amount of people interested in moving forth with improving maternity care. This title slide. Like most of the people that come up here, we're unfortunate to have no disclosures, or fortunate to have no disclosures. I think most people saw this USA Today article. If you haven't, just search USA Today maternal mortality, and you'll come up with this. Many of the hospitals there in red, you can just click on that state, you can click on your hospital, and you can get your maternal mortality, severe maternal morbidity rate. It was a rather eye-opening experience, I think, for many people. And then I don't think this slide is too unfamiliar to the people in this room, and we'll get back to that a little bit later. So when we did the maternal mortality reviews in California, it became, painfully obvious that there was really sort of four things that weren't happening. We were getting a delay in treatment, delay in diagnosis because symptoms were not recognized and they were assumed to be not significant. And I can't imagine that there's any of our nursing colleagues in the room that haven't said, well, that's exactly what happened in the last bad outcome we had. And if you kind of take that over to where you have severe maternal morbidity, near miss, maternal death, it just escalates up that pathway. And we saw that again and again and again. And so when then you take more of a scientific approach and you go, okay, well, what were the factors that were part of this, the deaths? The number one deaths you can see there were cardiovascular, but then quickly followed by preeclampsia, hemorrhage, and thromboembolism, and we'll kind of go back to that theme in a little bit. But delayed response to clinical warning signs was the number one item that we saw, which would allow for opportunities for improvement. And surprisingly, ineffective care. And I think, people have talked about people getting methogen through the night so the doctor doesn't have to come in as being, one of these sort of things. So if you go, and this data is a little bit dated, I made this slide slightly before the new CDC data came out a couple weeks ago. But if you look at the causes of maternal mortality in the United States, hemorrhage, sepsis, cardiovascular disease, hypertension are your main categories. 75% of the deaths fall into those silos. And here I pulled data from about 1 million births from the California Maternal Data Center, the Oregon Maternal Data Center, and the Washington Maternal Data Center in 2018. And you can see the numbers are a little confusing. It's 125% because if someone has a hysterectomy and they had a transfusion, they get counted twice. So that's why the numbers go above 100%. But if you take preeclampsia, sepsis, venous thromboembolism, and hemorrhage, it's 80% of the severe maternal morbidity. So if you want to concentrate on reducing your severe maternal morbidity, you go to the low-hanging fruit. At least that's what I think. And the lowest hanging fruit is really preeclampsia and OB hemorrhage, which is why I think most AIM states are moving, just like you guys, you're concentrating on OB hemorrhage and hypertension. That's why the Joint Commission put those things out that you guys all have to have in place by, I think it's July 1. So you think, what do we really want with a maternal early warning system? We want to get some sort of alert that tells us, things aren't going so well. And then whatever system you use, I have my biases, but I think I'll show you they all pretty much look the same. And then you want to apply that to your patient. And at some point where she gets between mild and severe deterioration, there needs to be some sort of intervention. You can't just get the alert and do nothing. You have to do something about it. So you get an activation, an intervention, and theoretically you should have a reduction in severe maternal morbidity and mortality. So measuring severe maternal morbidity is relatively easy. It's in the percentages. What was the state of Texas is about 2%, about the same as California. Maternal death, much rarer. Don't measure it in percentages, you measure it per 100,000 births. So it's a little harder to get your hands on. So these are the three common maternal early warning systems, the MUSE, which came out of Great Britain, the maternal early warning criteria, or MERC, which came from the Partnership for Patient Safety, and the maternal early warning trigger tool, which we developed within Dignity Health. Almost all the parameters there are based on expert opinion. There's some science associated with some of the ways these were chosen. We used information on what were the vital signs prior to an ICU admission. Others have used sort of different criteria. The numbers are slightly different, but they're kind of all the same. The MUSE uses a 2 yellow or 1 red criteria to get an alert. Merck uses a single value. We have sort of more of a MUSE approach. If you take 2 of the sort of yellow or 1 of the reds, the only difference is that we required the values to be sustained for a period of 15 to 20 minutes rather than a single elevation. And I'll come back to that a little bit later. So I think part of, when I was putting this talk together, I was going back and making sure, okay, if I reviewed all the literature, and a lot of things have come out talking about, well, and they're all retrospective analysis. Did the MUSE identify the hemorrhage? So in our maternal early warning system, which is shown here, we broke things down into 4 silos, which are, not surprisingly, as I tried to highlight, hemorrhage, hypertension, cardiopulmonary dysfunction, and infection and sepsis. But the hemorrhage part of it is really not designed to say, oh, your patient's going to have a hemorrhage, you need to activate your multi-stage hemorrhage protocol. It's designed to identify those patients who have already delivered or are antepartum and now are having bleeding that is not getting quantitative blood loss or even an estimated blood loss like you would see at the time of a delivery. But now their vital signs have changed. They've had a C-section, now their blood pressure is 80/40, their heart rate's 120. It's not something that you really want to ignore, because just because you're not seeing the blood, everybody knows, because it's all on the inside. The hypertensive pathway, it's really designed to normalize blood pressure. If you try to say, well, how many strokes did this prevent? Then you got to go back and you got to look at, okay, what's my incidence of stroke in my obstetrical population? It's very low. You'll never see it. The incidence is too low at a hospital level, and sometimes even at a state level, depending on your birth volume. And then infection, same idea. We had the talk yesterday on sepsis. The whole idea of the sepsis toolkits coming out of CMQCC, sepsis pathway here, and the other MUSE system is that you identify the infection, you alert your providers, you get intervention earlier or identification that the patient already is sicker than you anticipated. So I think you have to think of these not so much as they're going to immediately cause a reduction in whatever element triggered, but you're trying to get that earlier intervention. Ultimately, when you look at enough cases, you should see some positive results. And then, of course, there's the value of early detection. There's a study here from Marcy Bauer looking at, severe sepsis cases, whether they got antibiotics with 1 hour or not with 1 hour, and it all sort of falls into the Save Sepsis campaign approach. So I think you have to think of Muse in really 2 formats. One is recognition, okay, something's not going right, followed by intervention. And if you simply have the identification without a standardized intervention, I think you'll be completely unsuccessful, and you'll move the needle 0 on the dial. So this is, excuse me. So this is part of the Muse for the TCHMB. You can see it has exactly what, at least I would think, is important. It's got a trigger, concern for OB hemorrhage, and it's got an intervention order set. We'll come back to that a little bit towards the end. Recognition, alert, standardized intervention is the way I think that these will be successful. So the question really is, do they work? I propose that they do, and I'll show you, why I think so. And so we can look at how do we measure do they work by process. So did we improve the processes of care for the patient? So did we increase the percent of the providers that actually use the tool in a standardized intervention like treatment of hypertension? Did we get a timely bedside evaluation? And did we get the intervention that we wanted? So when we reported in 2016 on about 10,000 patients using our maternal early warning trigger tool, we noted that we had a reduction in the time to treat critical blood pressures, that physician assessment occurred in less than 1 hour at the bedside in 80% of the cases, and the clinical pathways were followed 80% of the time. The only real deficit that I could see from laying out the data this way is I really don't have a so I don't know if there was someone who suspected it had hemorrhage, what was the likelihood that I would have had a physician at the bedtime prior to initiating this tool. This was carried out, as I said, in 6 different maternity sites with the size of the delivery units being between 800 and 3,000 births annually. So this is Elizabeth Blumenthal. She's down in Southern California at Long Beach Memorial Hospital, and so she looked at a retrospective, actually this was her prospective data. She did a retrospective view, then a prospective data, looking at these various sort of process measures: time to antibiotics for cases of suspected sepsis, care escalation within 60 minutes, i.e. a provider at the bedside. Bleeding to first transfusion wasn't quite statistically significant, but the N is really not large enough, I think, to reach that. And then bleeding to balloon placement. So significant process measures that improved with the utilization of maternal early warning. They use the mute at their institution, but I don't think that would make any difference. And I'll come back to this again in a little bit, the Muse trigger rate was 2.3%. And that's an important number to remember. So then, do they actually improve, not processes, but outcomes? So you could measure outcomes by return to normal vital signs, reduction in severe hemorrhage, reduction in severe maternal morbidity, or some sort of composite outcome. So this is data from our own system. We saw a slight increase in the rate of total transfusions, but it's almost 60% reduction in the incidence of DIC. Most patients will not die if you give them a transfusion unless you've really messed up, but a lot of patients die once they develop DIC. So this was an important outcome measure for us. When we looked at a variety of other elements, composite morbidity, severe maternal morbidity, as well as some of the other elements there, eclampsia, hemorrhage, transfusion, DNC, hysterectomies, they all moved in the same direction. We had a cohort of 50,000 patients in the post-time period at our non-participating trial hospitals. And a lot of the things that we've published, the sort of acronym that I've been told by our nursing leaders is that they get volunteered to participate in some of our studies. But in the end, I think it all works out. And there you can see everything moved in the opposite direction. Either was no change or the actual rates went up. If you look at severe maternal morbidity associated with preeclampsia from rapid aggressive intervention with your blood pressure medications, we also utilize magnesium sulfate, and I don't really want to get into that, but for all of our cases of critical blood pressure, you can see in the pre and post-time periods, there was significant reduction in our preeclamptic severe maternal morbidity. So this is hemorrhage excluded. So we had that earlier slide, and so I was putting this talk together, and I was so happy to run into your website and some data associated. This sticker sat on my desk when I was in medical school. So same thing, early intervention with the Muse and reduction of blood pressure back to normal. This is data from Texas at your guys' institution, I believe. Adverse events, composite adverse events and transfusion of greater than 4 units. Highly significant results. The reason I was so happy with this, because now it wasn't just, some, group out in California that says they can improve healthcare. It's actually, other people across the country looking at it down in Southern California, but also in Texas. And then, this is just a visual of the composite events there. So I think that, so they really work. Yes. They work with process measures improving patient care, and they reduce adverse outcomes. So I think that there's now enough compelling data that suggests that these should be present in every maternity hospital in the country. They aren't without logistical issues. One of the common sort of feedback you get is, well, you guys tested it in, California and big hospitals, and, I'm in a rural community and we only do 1,000 deliveries. This won't work for us. And I would say, not true. So these are the size of the maternity centers where we have this actively going at this time. It's not all of them, but just to give you sort of a flavor, they vary from almost 5,000 deliveries down to 339. And so it does work. Now, how do you set up your alerts and who responds to those and how that happens? That's going to vary whether you're at a center that has 24/7 in-house anesthesia, OB fellows, OB residents, to a place where all the doctors are at home and your nursing staff are there. But it still allows you to do it. So it will work at all sites. The other thing that comes up is, I'm really waiting for my EMR to come along and fix this for me, and I really want it to page me when there's an alert, and then I would like to be able to push a button and my automated ORSATs come up, and then the nurse can call me if it doesn't work. Well, if you wait for that, most people in this room will be retired. How many people can get something changed in their EMR in a month? 2 months. 6 months. Okay, we got a few hands at 6 months. Okay, and then if there's a mistake, how long does it take to get changed again? 6 months. Okay, it's no different in my system. I'm telling you, it's just the way it is. So, and there's some logistics of getting all the logic correct. We've gone through many iterations of putting this into the EMR. We started on paper. We did 10,600 patients on paper. We sent 10,600 pieces of paper to a central office for collation and data analysis. So you can do it, but if you you should figure out what your resources are. Some large facilities, some large healthcare systems are doing this. Cerner is currently working on a build for this. Epic has worked on it. Some of the private add-ons, Pascal Metrics, Paragen also have similar type elements. But if you really want to make a difference, just start with paper. Wasn't expecting that, but there you go. So, and this is an example. So we presented our data at the Society of Maternal Fetal Medicine in 2016, and the following year I was asked to lead the scientific sessions, and you have a lot of leeway, so you can choose whatever you want to do. So I chose maternal early warning systems, and so I invited Mary Campbell. She's from a small hospital in Atlanta that does about 1,000 deliveries a year, and this was her version of it. They posted it on the wall. The nurses had a little form that they filled out, and they called the physician if they met the criteria. Very simple. No EMR, no paging system, but specific interventions and what they wanted to do. This is the paper form we used. If you want it, I'm easy to find. I'll send it to you. So then, we talked about, and I forget who talked about it. I think it was Dr. McKay. Who's the captain of the ship? Whoever the captain of the ship, or whoever thinks they're the captain of the ship, needs to show up. And there's a variety of ways to do that, depending on your hospital. If your provider's at home, which most smaller facilities are, people forget that 75% of the births in this country occur in facilities with 1,500 deliveries or less. They don't have 24/7 everything you could imagine at their hospital. So you get an alert, you call the provider. The provider can then, if it's a true emergency, see if there's another provider at the hospital, or if your provider's in-house, they can go and take care of this for you. You can initiate your standardized order set, and then you can come in to see what's going on. In our system, in Dignity Health, they can initiate their first treatment for blood pressure, and they don't have to come in if it normalizes, and then they get them started on MAG, and they may start them on an oral medication at the same time. If the patient appears to be septic, yeah, they have to come in. It makes sense. So that you have to model what resources do you have, and what's reasonable to accomplish in your hospital. But staying at home is not one of them as you escalate care. I talked a little bit about this. So in our system, we utilized you had to have greater than equal to 2 triggers, and it had to be sustained for 15 to 20 minutes. This increased the probability of an ICU admission from an odds ratio of 10.2 to 60, almost 62. It reduced alarm fatigue. I showed you the frequency of alarm fatigue from the prospective study done by Dr. Blumenthal at about 2.2% of their system, which is remarkably low. So the argument, well, I don't want to get called all the time. Okay, the nurse is going to call you 1 out of 50 of your births, right? If it's 2% essentially. So not that often. And it reduces the alarm fatigue, because, nobody has been in a labor and delivery unit and not walked down the hallway while an alarm's going off and no one paying any attention to it. So that's really not what we're looking for. So in the Muse system, which is a single alert, this is a retrospective study on top from Dr. Blumenthal. They looked at, sensitivity, specificity, PV positive and negative, and more importantly, what number of control patients had a positive alert. So if you have 40% of your control patients getting a positive alert, you're dead in the water, in my opinion. No one's going to pay attention to you. No one's going to come to the hospital. You're just wasting your time. Where we used the sustained alert, it dropped down in her retrospective analysis to 11%, and then surprising in her prospective analysis, which is the second one there, it was 2.3. In our study, it was 2.9. I think at your guys' hospital, it's about 7%. You have a probably not normally distributed risk population would be my guess, knowing what I know. So that's not too surprising. So then there's buy-in. So The most common thing I think you're going to hear are the first two things. Well, the system fired, and I didn't think anything was wrong. And every time I get one of those alerts, my patient looks great. It's not supposed to just alert when your patient's ready to get admitted to the ICU. It's to prevent them from going to the ICU based on data that suggests that if you intervene at this point, you will change the outcome of that patient. And I think you have to think of it in those tunes. And then you have to have some sort of standard response. Everybody at your hospital should agree, this is how we're treating blood pressure. If it's 165 over 95, they're going to get treated with an antihypertensive and decide whether you're going to treat them with MAG. I have a bias there. I can show you the data if you're interested. And what are you going to do if it comes up again? What are you going to do with hemorrhage? Everybody in the room here, I think, has a multi-stage hemorrhage protocol in place now. Same thing with sepsis and if there's suspected cardiovascular issues. It's recognized. Everybody just says the same thing. The nurses know exactly what to expect. They get a high blood pressure. Dr. Shields, the blood pressure is elevated. Which medicine would you like to use, labetalol or hydralazine? It's really that simple. And then you got to figure out, based on the size of your institution, what are you going to measure to see how you're working? For most places, it's going to be a process measure because you're not big enough to measure outcome measures. For a large system, you can do process and outcome. And so I think those are sort of important elements there. Where should it be located? This is my hospital. There's 3 charts there. Our mute chart sits up front, followed by, we have a standardized response to category 2 that's not part of the study, but it was there, so I figured I better label it, and our hemorrhage policy that sits there as well. At every nursing station, we have like 20 pods at our larger facility. It's posted at every single one. It's posted in the resident room. So you have it around. If you have it in the nurse break room, you might as well not even put it up. No one's going to see it, and they're not going to be able to access it when they need to. So I think there, I'm happy to entertain questions or comments.
Thank you so much, Dr. Shields. If anyone has any questions, please come to one of the microphones. Dion.
Thank you for the presentation. We're actually doing Muse in our facility. I think we're at June 2018, so we're at like 18 months. And of course, we've had challenges, as I'm sure you did too. And I just wanted to know how you came up with the sustained trigger for 20 minutes. And because that's what I'm understanding, that the trigger had to be, the vital sign had to be out of range for at least 20 minutes sustained before you activated. And the second question, if I understood that correctly, the second question is, how do you handle re-triggers? So the patient triggers, you stabilize, the patient re-triggers, you stabilize, the patient re-triggers, because they're chronic hypertension or preeclamptic. So those are my 2 questions.
So the first one, if I understood correctly, was related to how did we decide on 15 to 20 minutes? So the first study we did was looking at a series of ICU admissions and then trying to figure out what criteria could we come up with that would potentially alert us to the fact that this patient might require admission to the ICU. And that's where we looked at, we could use one trigger, wasn't of any value. It's just because your screen positive rate's too high. 2 triggers was pretty good, but still the screen positive rate was, I think, 10 or 15%. And then we marched it out to 15 to 20 minutes on the time separation. Was it sustained here? And 15 minutes later, was it still sustained? Sort of like you do with your hypertension AIM bundle. And that's when we were able to reduce the likelihood of the frequency of the alarm being triggered. And so that it was really playing with all the numbers and then deciding what was a reasonable value for it. And then as far as re-triggers go, if the patient is in the hypertension is the easiest one to deal with because it's probably the most frequent that's going to trigger. And so they get a trigger, they get an order, and then they escalate if it's not coming down. And then, as long as it is normal, we don't ask for a retrigger for 2 hours once they normalize it, or they're working on it. So like if they're still in the midst of it, it's triggered, the nurses responded, they're giving their blood pressure medication, it's not going to keep re-triggering every 5 minutes while they're checking the blood pressure as they're giving, because then it's just a screen pop-up that's going to drive you nuts. Right. And that's some of the logistical things to sort of play with and see how they work. And a lot of it is simply, you think you got it right, and you didn't. That's why I'm saying if you're really just starting this and it's not in your EMR, just go to paper. You'll get the same results. You might even get better results.
I have one more question. So, so my final question is, at what point do you require a provider to come to the bedside? So, because we use our Muse to, if they trigger, they need to come. So I know you talked about in some instances, I guess maybe with smaller facilities where they don't have resources. Right. So, do you have a requirement that if they trigger and you have the resources, so we're at a tertiary care center, so we do have the resources, do our providers need to do a bedside eval?
Right.
For
the
those
only
triggers?
one they can give the initial order set for any of them, but then the only one that doesn't require them to come in would be hypertension and a single dose. So they would get their first dose of labetalol. They require the second dose, they have to come in. And then the question is, well, what if they don't? So we have a lot of standardized policies, and I have some of my colleagues from some of our Texas hospitals here, because we've expanded, which is a totally different story. But within Dignity Health, the way we handle that, amongst the 29 maternity centers and 600 obstetricians, they could decide that they did not want to follow one of the standardized algorithms or policies that we put in play, but they had to come write a note to do it. And if they didn't, and then their note or non-note would then go to peer review for review, because sometimes there may be a very, you can say, well, that would just get you what you wanted, and it's like, well, of course, that's why it was designed that way, but the opposite of that was, there may be a very legitimate reason why somebody didn't do something, and they shouldn't be really penalized for that. So, but as long as they were willing to come in and write a note, and we had some providers that did that, and they went through peer review, and they were fine, and other ones that it's like, okay, do better next time, right?
I have a question. Some of the things that we've been hearing from some of the hospitals we're working with is that folks don't feel there's a lot of evidence behind Muse, and so their hospitals are trying to prove to them that they're effective. So potentially not using studies such as yours to feel like they're showing the evidence behind it. So they're working on collecting data if they're implementing Muse to show that it's been effective. And it seems to be a motivating thing in some facilities. Since your triggering wasn't initially in the electronic medical record, how did you collect data about outcomes to show that it was effective, to kind of build that common agreement that it's working?
So I'm going to make a comment, editorial, and then I'll tell you what we did. The comment for editorial is, the more data that gets put out there, the easier it's going to be to convince people to do things. No pressure on you guys, but get to work. Okay? We've already talked about that. That's why they're sort of laughing at me. But I mean, it really, the proving that it worked, I think, has come a long way since we first published the data in 2016. Prior to that time, there was a single prospective study. Yours will only be the 4th prospective study looking at the effect of Muse. There's a gazillion review articles. There's a gazillion retrospective analysis of if we applied Muse here. There's a lot of articles saying, gee, everybody loves their Muse. The Muse that was tried at a single hospital in Great Britain, I believe, had a 40% screen positive rate, and the numbers were too small to make any conclusions on outcomes. The study from Elizabeth Blumenthal puts the next cast into applying process improvement measures as well as outcome metrics, whereas you guys have looked at it in a very high-risk setting where you show significant improvement in outcomes. And so the layers are starting to form that weren't there years ago. So to your other question was with regards to how did we get the data? We did everything on paper and then used the administrative data system to look at the outcomes that we looked at for severe maternal morbidity and the other elements.
I hate to beat the hypertensive thing to death, but I just want to make sure I'm understanding correctly. If I've admitted somebody, I saw them in the office, their blood pressure's high, postpartum, I take them to the hospital, I see them, I set the protocol, and then I step away, and 2 medicines later, it's still not down yet, but we're seeing a trend that it's getting better. Does that activate a re-trigger for me to come back in? Or is it just when it's like a new thing? That all of a sudden, oh, she's hypertensive, no one knew, no one saw that. You need to come in and just make sure.
So if she already was at bedside, treated the hypertension, and then it remains persistent in your system, would she have to come back to bedside?
So I just want to make sure I understand. So patient's gone to the hospital, she's triggered for blood pressure.
Well, she delivered already, and I've seen her back about, I don't know, 8 days later.
Okay.
And she was feeling great, but her blood pressure was 170s over 105.
Right. So she goes back to the hospital.
I take her over there, and I've seen her, and I've done the orders, and this is what we're going to do, and I step away. So 2 medicines later, because you were saying, well, you gave her 2 doses, and it's a trigger, now you need to come back in.
So you don't think you should be at the hospital if your patient has critical blood pressures and they hadn't responded to therapy? Is that what you're saying?
Well, I'm saying if it's starting to come down, but it's still not at below the trigger, and I come to the bedside, and I'm just waiting for the nurse to give her the next dose, and then it's better. So I'm just trying to get a sense as to, because when you're in a smaller community, and if you're in a bigger organization, you have more manpower, but when you don't, I guess that's where the note comes in, when you're like, this is why I was not there. I'm giving orders verbally, you know what I'm saying? Because
right.
If you're on call for both GYN and OB and you're trying to be at multiple places, I guess it comes down to just writing a note as to why you didn't come to the bedside is really what it comes down to.
That would be one option, or one option would be, where am I most needed? Where's my most critical problem right now? Mm-hmm. As my nurse is hitting up with, 80 milligrams of labetalol, I might want to be there to find out whether this patient is going to respond, not respond, whether she might have to go to the ICU for, more critical blood pressure control.
The patient was fine at the end of the day, but I just wanted to make sure I'm being clear, because I don't want to blow something off that I shouldn't. So thank you so much for answering my question.
And one of the things that Carrie and I have talked about as we've worked with other hospitals is you can kind of tailor it to your hospital, as Dr. Shields mentioned, and the resources at your hospital. We work with the exact same residents at 2 different hospitals, and it's the same system with very slight modifications to it. And part of that is in the re-triggering. And so I think that's something that you have to kind of decide what's going to work best for your hospital. The other thing in terms of alarm fatigue, so we went live with one hospital many years before the other one actually, and we were using the Merck criteria, so the single trigger criteria. The diastolic blood pressure in that criteria is triggered greater than 100 millimeters of mercury. And after how many months would you say it was?
3.
After about 3 months of looking at the data, what Dr. Epps realized was that every time we were triggering for greater than 100 but less than 110, we weren't really doing anything. We weren't giving medications, and there was nothing else to follow. So then she changed the criteria to 110. And so then that also brings down the frequency of which you're triggering, and it increases the likelihood that there's, even though there's the intervention as a provider at the bedside, it would most likely result in an actual treatment of the hypertension. So at both of our hospitals, I would say using the single trigger, but changing the diastolic to 110. So when we went live at our other hospital, because I already knew that, we just started out with 110. So we have about a 7 to 8% trigger rate using the single criteria, but changing the diastolic from 100 to 110. Oh, I see a question over here, sorry. This will be our last question.
Yeah, Dr. Lowry, University of Arkansas in Little Rock. As we begin to do these protocols and interventions, whether it's this or remote patient monitoring, those sort of things, we have to begin to look at the information and set thresholds for these sort of things. And it's very kind of rough right now as to, you know, there's a balance between false positives and, you know, false negatives, and, you know, false negative can be deadly. Have y'all looked at any other kind of machine learning, deep kind of processing that might add credence to the, to decrease the false positives? Because, you know, like with sepsis protocols, for instance, where AI has been involved, you know, humans can screw up the intervention easily by ignoring the alarms if they're more frequent. So I think we're going to have to be very careful that you know, we don't overpower everybody with alarms going off in many different areas. And so, I mean, what do you guys think about? I mean, I'm for this stuff in a big way. Don't get me wrong. It's just in the, like you said, the UK study, 40% false positive rate. And I remember the old days with fetal heart rate monitoring, same thing. We had all these alarms that when it was automated. So are you doing anything to extend this beyond?
It's a great question, and I think that we will see, now that we've, in my opinion, have enough data to suggest these really do work, the next stage is the, you know, how do we and if do we modify them based on some of the things you mentioned, like machine learning.
Yeah, thanks. And particularly the postpartum stuff seems to have a lot of false positives, because we didn't know about a lot of the blood pressure problems in the postpartum because we didn't really monitor it that much. Right. So.
Thank you all, and thank you so much, Dr. Shields.